Well, I'm not, oh. Okay, I'm going to actually bring on Dr. Rasu Shrestha, who is then going to bring on his distinguished panelists. I just wanted to say a word about the Center for Connected Medicine. We're thrilled to be able to be in this beautiful site, which is, as I understand, is the world's first collaborative healthcare executive briefing center, and it supports a lot of partnerships looking towards the future of medicine, transforming medicine, and things are happening so quickly in this day and age. And we're just delighted to be able to hold something focused on health and the future of health in such an amazing facility. And I think Rasu, Dr. Rasu Shrestha, is going to, along with his panelists, describe what they're working on and how that's connected to the Center for Connected Medicine. So Dr. Shrestha, if you would come up, please.
Thank you. Hello, everyone. My name is Rasu Shrestha. Please, Harry, Jörg. So my role here at UPMC is I'm the Chief Innovation Officer for UPMC, and I'm the Executive Vice President for a group that we call UPMC Enterprises. It's really pushing the agenda around innovation, entrepreneurship, commercialization of remarkable healthcare technologies. We have an awesome panel to start off today. The hour-long panel discussion that we're going to have is going to be divided into two groups of panelists. The first half is just remarkable, and it's the representation of some of the strongest of folks in the industry that are pushing healthcare to the next level. So on my left, I have Jörg Debatin, and on my right, I have the legendary Harry Reynolds from IBM. I'll let Jörg and Harry just introduce themselves, if that's all right.
Well, thanks very much. So my name is Jörg Debatin. I grew up in Germany. I trained as a physician and became a diagnostic radiologist. For those of you who are not radiologists, I know that you are one. It's the funnest part in medicine. Unfortunately, I was lured out of this wonderful environment around 2003 and then started entering the dark side of medicine, that is the management side. I ran a large university medical center, the University Medical Center of Hamburg, for about a decade. And 2 years ago, came to GE Healthcare, where I have the privilege of filling the most fun role that you could possibly imagine. I lead the science and technology organization of GE Healthcare. Initially, I have to admit, I thought that kind of made a mistake in their recruiting because I'm not an engineer, I'm a physician. But at the end of the day, I think we are beginning to recognize that it's not only about technology. Obviously, GE is a technology company, an industrial digital company. But it really is not technology for its own sake. It's really technology to serve patients and to advance healthcare. So that's really what I'm doing with a very broad portfolio that we pursue at GE Healthcare, all the way from what you may associate with us, the imaging, the CT scanners, the MR scanners, the X-ray equipment, ultrasound. But we're also actually very involved in monitoring and anesthesia, respiratory. And then there's two areas that you may not be so familiar with. One we refer to as life science. Basically, we make machines that produce protein-based medication. In fact, 90% of the world's insulin supply comes of our machines. So we know a lot about how to program bacteria so that they actually do the right thing. So we have a lot of molecular understanding, which really helps us in and around the new emerging field of cell therapy. So we're very strongly invested in oncology, autologous CAR cell therapies, all that sort of stuff, which is terribly exciting. And then really sort of top it off, we're heavily invested in IT and try to sort of use IT as an umbrella, as a bridge between these various aspects of our portfolio, which obviously is sort of the new wave. And I already mentioned that Jeff Immelt, our company chairman, is very busy transforming our company from an industrial to an industrial digital player. And I'm sure we'll talk more about that as the panel discussion goes on.
Absolutely, and indeed, you mentioned Jeff Romoff. He's actually going to be here this week at UPMC. Harry, please, if you could introduce yourself.
Hey, good morning. I'm Harry Reynolds. I'm the Director of Health Industry Transformation for IBM's Global Healthcare and Life Sciences team. I've been in the health industry for 48 years in the technology side. I started out with IBM, and my first job was to sell technology to doctors and hospitals in 1969. I got rejected through plexiglass windows in doctors' offices more than anyone you'll ever meet. Right? So I have seen it from the beginning. So when I talk about transformation, I've lived every bit of it. I had the opportunity to work for IBM first, then 2 teaching hospitals, and then a large insurance company for 32 years. And now back with IBM for the last 7, where I work with all of our customers, all of our projects, and all of our strategies as it relates to healthcare. Most of you know IBM from the data center. Most of you know IBM, I would tell you get over that. That is not who we are anymore. We are very good at that still, but we are dramatically different as you move forward. We'll talk about our most recent capability, Watson, here in a minute with one of the questions that Rasu has, but understand that we are now, we have created a capability that is going to, I think, revolutionize, and I'm comfortable enough in the industry that I'd say revolutionize the ability to share information with people all the way down to the individual person, and I'll talk about that as we go through it. But our chairman and president, Ginny Rometty, calls this our moonshot as we try to dramatically influence cancer as well as other things, and I'll get into those. But just know that we're not the IBM you knew. This is not the world that we have watched transition. This is a dramatic change, as Jörg said with GE, as we said with IBM, offering capabilities to people, as it was mentioned, the underdeveloped countries. I'll touch on that when we get into Watson and other things. How do you take the capability of the best, put it in every possible environment, and let the people that still do the right things do the right things, rather than deciding it for them? So exciting times, really happy to be here, and we'll get into it deeper as Rasu asks questions.
Yeah, thank you, Harry, Jörg, for the kind introduction there. So this next hour is going to be a remarkable set of discussions. The first half really with 2 industry stalwarts, and then the second half we're going to dive deeper into 3 panelists that we'll have here on the stage, 3 of the most remarkable groups that are coming out from this region and making an impact globally, right? So we're starting with the industry here. And you mentioned earlier, Harry, that clearly there are lots of things that are being transformed in the industry at large. And one of the things that we're seeing in the industry today is this transformation from analog to digital, right? We're embracing the digital form factor in healthcare like nobody's business. But at the same time, what we're seeing in the United States and internationally is this massive adoption of electronic health records and clinical information systems, where we've gone, even in the last 5 years, from about 8-9% adoption to about 90% adoption in the United States. And we're seeing similar numbers come up internationally as well, as was discussed earlier. What's key in all of this is what's next? Right? How do we take healthcare from where we are to where we need to be? How do we move the discussion from it being about sick care to well care? How do we engage consumers in the decisions that they need to make in their own health and well-being? How do we move the conversation from volume to value? So with that as the backdrop, I'll start with you, Harry. Right? So Watson has been out. It's played Jeopardy and won it brilliantly, and it's now assisting in finding a cure for cancer. So tell us how real this is to the everyday person and why it's not just hype.
Well, what's exciting is, as I mentioned, we developed the capability. But the capability needs to be delivered by experts. So I'll just use Watson Oncology as an example. It was developed along with Memorial Sloan Kettering, very prominent oncology environment where they literally were able to take the capability we've created, educate it in oncology. The exciting thing about it is it can ingest all the available data in health. So whether you talk about the New England Journal of Medicine, any EMR, anything, and I think all of you know there is so much data as it relates to health that is unstructured. So doctors' notes, nurses' notes, those things have tended to be, in my career, dead data. They didn't necessarily get pulled up. And so that knowledge that a number of you are doctors in the room that you wrote down didn't necessarily get ingested and make a difference as it could have. So all that is being able to be brought into the new technology that we have. And with MSK, we have created an oncology capability to diagnose as well as recommend treatment. So just like UPMC was discussing telemedicine, well, how can we have all the doctors that have worked together to put together our Watson Oncology in the room with any doctor anywhere in the world? Taking the data from them and sending it. And again, I think another thing to remember, as a service, not that you have to buy huge amounts of technology, you don't have to make major capital investments. We're talking about this data being in a cloud. We're talking about the capability of accessing that data. So you don't have to have, what you used to have, dramatic technology on the ground to be able to use these services. So, and then you use it as you use it. So if you use it 15 times, fine. You pay for it 15 times. You don't pay for it, as if you're going to use it 1,000,000 times and have to put so much capital up. So that's the exciting part of that. But it's, and again, it's a system that understands, reasons, and learns. And I could stand up here and say that to you all the time. You need to see a demo. Because when you see it and when you see what it came up with as a possible 11 diagnosis the first time it gets a record, and gives you degree of comfort. And then you can click on each one and it'll tell you how it came up with it. So which literature, which findings, which other things did it use to do it. So it's not, then you can do that. So it's being used a lot in teaching, it's being used in other things too, as you go about it. After that, give it new information and it will change the degree of comfort in the description, just like an individual doctor would do and so on. And again, it's an asset to existing caregivers. It's not that we're going to be doing it. And so I think that's exciting. A couple other quick comments I'll make on that is it's not just oncology. It's diabetes, it's sepsis, it's in life sciences. Clinical trial matching that was mentioned early this morning, where any person can have their information put in and it goes against all the clinical trial matching around the world. So again, these ideas of how can you create capabilities that cross boundaries, cross situations, cross diseases, and create it in a way that can be delivered to every individual person and so on. So lots of things that it's doing. It's a capability. It's going to be in many, many different environments. Healthcare was our first and is the one that we are significantly investing in dramatically as we do things. And you can see by some of the companies that we've purchased, Merge, which is a large diagnostic imaging, a couple of others, and then we actually bought the weather company. And we will be bringing the weather data in through Watson to evaluate what effect weather can and does have on care. So just think of asthmatics and others as you do that. So we literally know the world's weather and are able to use that. So those are the kind of things, because Watson needs data, Watson needs information, and then we need to train it with the right professionals so that, again, it's representing them. It's not a technology company acting like they know everything about health.
That's remarkable. This Watson is fantastic, everything that we've seen in the media, but also read in some of the great work that Watson's doing. We talked earlier about how we're data rich and information poor. And much like IBM, GE is also making great strides in transforming industries across vertical markets, not just in healthcare. And then GE has this remarkable effort around what it calls the industrial internet, Jörg, right? So how does something like the industrial internet impact the everyday life of a patient?
Well, one of the things we could do better as GE, and we can learn from IBM, is really with regard to making the big splash. And compliments to Watson, I think it is terrific. It really catches people's imagination. But equally important, I think, is what you mentioned, the Internet of Things. It may be less sexy or less sort of splashy, but what really impressed me, and this is nothing that came out of GE Healthcare, I have to admit, it's something that where we really bank on the big size of GE overall, and it's driven more by our GE Aviation and our locomotive factory. And what they sort of came up with is the need for machines to start interacting with one another, or at least sort of machines producing data and us using that data to predict how these machines are going to perform. So we have developed the concept of the digital twin of an aircraft engine. What does that mean? It basically means that we get data in real time from aircraft engines all over the world, and we try to use that data to predict what is going to break in that engine next. So this obviously has huge ramifications if you are in the service business. You don't have to take this engine out of service at regular time intervals, but rather you sort of look at the exact data and you try to sort of predict what's going to go on. Now, we actually use the same concept in the medical technology arena to predict when our CT scanners will break, to predict how coils will perform in the MR arena. And that's sort of a translation that's, I think, doable, and that's easy to do almost. The next step to me, though, is how do we translate that concept of the digital twin of the aircraft engine into the digital twin of the patient? And this is where it becomes really interesting. And this is obviously, there is a slew of data, so this is not a matter of not having enough data. I think everybody has enough data. But what we are banking on are really two, I almost like to call them IT revolutions, one of them being the cloud, that doesn't only give you unlimited storage and unlimited computing power, but it gives you in medicine something that is very unique that we didn't have before, and that is the ability to connect everyone on an individual basis. Even today, when you talk about EMRs, we think about electronic medical record systems as being institutional based. So UPMC owns their data on their patients. I think as we go into sort of the digital twin of the patient, we have to turn this and actually have to define the patient as being the common denominator for the data. So we'll have sort of Jörg's data in the cloud that will actually be comprised of what the data that I actually have here at UPMC, as well as in Germany, as well as in France, as well as sort of in the doctor's offices, as well as maybe the wearables, my other habits, my eating sort of habits, et cetera, et cetera. So it's really the ability of us to move away from an institutional way of handling data to the individual patient data. That, I think, is a big enabler. And the second big revolution in IT, quite frankly, to me, is machine learning. We're talking about what we can do today with algorithms that are rule-based, much like a medical student would study a book, and Watson reads that book, and our sort of algorithms read that book, and we can absorb that knowledge and apply it. What really is interesting to me, though, is the ability to learn from experience. This is like the equivalency of what a resident does as they go through residency, where you go approach a patient, you look at the patient, you see their taint, you see the way they act, you see the way they move, you look at their temperature, you integrate everything, and that's what physician experience really is about, and that's something that a machine can learn. And to me, the opportunity that opens is absolutely huge. This is, I think, where we're going to see the most progress. As GE, we have developed a not so flashy name, but it's called Coolidge. It's an algorithm that runs on that enables deep machine learning algorithms. And to me, I think that will changed the world, changed the way we think and practice medicine in a very, very fundamental way.
That's
and
remarkable.
it's just really, look, if you have a big problem, you like to go to a physician who has 30 years of experience. Just imagine if you could go to a machine that has 1 billion years of experience. And that's really the difference, right? And that to me is the fascinating part of deep machine learning.
So it's remarkable, whether it's GE or IBM, building these capabilities, bringing these capabilities that are able to crunch through large amounts of data sets and really transform the care processes. And what's interesting about both of what you've mentioned is it's not just about implementing technology, but it's really about leveraging technology to humanize the care process, to really transform, cost models and care processes at large. And so one of the questions that I had for the both of you is, around population health, right? So population health is a big buzzword today in the industry. Everyone's talking about population health, and it means different things to different companies and different individuals and different groups. But at the same time, it's remarkable that we need technology to look at, how do you manage risk across populations of patients, and how do you really look at how we manage care processes in this new world that we're dealing with. So I'll, ask both of you an open question. What's your outlook on population health? Maybe we'll start with Jörg.
If you know what, before Harry maybe wants to take a first stab at that, let me just sort of focus on one point that you mentioned, and that is, what is keeping us from adopting these technologies? I don't think it is so much technology. I don't even think it's so much the understanding of where we create value with these technologies. I think Watson is demonstrating that. We have examples of demonstrating that. The real question, and that's something that I'd like to throw out also to the audience to consider, is how do we make this real in a medical environment that, quite frankly, is very conservative? And it may be conservative for all the right reasons. But if you just consider how long does it take the Society of Internal Medicine or Infectious Diseases to change the antibiotic regimen on any disease, it takes an average of 5 years. If you think about how long did it take us to embrace the concept of EMRs in medicine, I think we need to sort of figure out how do we engage sort of the medical community more, and how do we deal with the fears that are associated with these changes, and how do we make this real and showcase this and move this from the flashy PowerPoints and the flashy stories that we can tell to real life. And that to me is a very fundamental question. But now back to population health.
What's your outlook on population health?
Yeah, well, I think a couple things, and I'd like to play off his comment in a minute. How many of you use a GPS when you're driving? How many of you think you're good drivers? GPS has delivered a capability to you that allows you to go anywhere, anytime, do anything. Most men decide whether they're going to turn left or not, but there's always that recalculating that we deal with. But the fun part is we're good drivers and we still get to drive. But look at what it has brought to us. So back off of your comment. So think about the technology and the capability that brings you continually updated knowledge, continually recalculated. And every time you touch it, it does it. But the doctor's still the doctor and the patient's still the patient. And oh, by the way, the patient, when you talk about population health, is a person. And so one of the lists we've started dealing with more is we put member of an insurance company and patient last. If you think of population health, they're a person, they're a consumer, they're a parent, they're a child, they're a caregiver, they're a grandmother, a grandfather, and so on and so forth. Then, oh, by the way, periodically, they're a patient and a member. And so consequently, thinking about the person. So as you think of population health, which population is the first question I always ask? Because everybody wants to use that word, and then we can have a conversation back and forth, but we're talking about two different populations. Somebody mentioned aging today, somebody mentioned chronic, somebody mentioned this, somebody mentioned that. So the first thing is which group are we talking about? The other thing that's important is, can you compare your population against a bigger population? So one of the things we have done as it relates to population health is some of the companies we have bought. Wouldn't it be good? So even though UPMC is magnificent in what they do, can they compare their diabetics against 3 million that Watson has? So those are the kind of things, just so that you can use the technology and the capabilities to evaluate much bigger than you are, but practice how you choose to. Again, back to that same, how do you drive? Same kind of thing. You can do those. So I think those are really important. And then the social determinants, things like transportation. It's always fascinating when you look out of this building at all the bridges and tunnels. You'll see both UPMC and others building more of their facilities out where people live. If you want people to become part of healthcare, go to them. So as we look at population health, it's against the bigger population. The next thing is it has to be in their language. So Watson, for example, now handles 9 languages, of which Arabic is one, making sure that's there. And second, to every device. And I thought Jörg made a great point. Am I 22 and I only deal through my smartphone? And am I my age and I might want to talk to somebody? And we've made Watson and other things conversational so that you can have those things. So the fun part is, don't discredit it. Think GPS and think what can add to your capability and bring you dramatically different kinds of knowledge to your hand right now about that person. So the population of 1 versus a population of 3 million versus a population of a whole country. That is the thing that bounces me out of bed every day, because we are going to change the world as a group. That's the people that are already delivering care plus the people that are trying to bring the assets to them in a horizontal and a vertical way down to you as a person, and do it. And I'll make one last comment about population health. So everybody has a population. So there's an employer in the U.S. that's going to be offering second opinions through Watson using a certain set of doctors. It's going to be offering personal clinical trial matching and going to be offering genomics. So those are the kind of things down to the individual person that an employer, because the employer is trying to take care of a population and have some kind of stickiness to them staying as an employee. So again, these are the kind of things that we're all trying to deal with horizontally, and we are specifically, but with the right partners. And the next part of the program you'll hear about, this is about partners. This is not just about either one of our companies, for sure.
That's remarkable. The analogy between GPS and what we need to be doing in healthcare, especially as we're looking at population health. What's your outlook on population health?
Well, you know, we're quite heavily invested in population health. We have a company called Caradigm. We're touching more than 300 million lives as it is right now with Caradigm, which is involved in 250 sort of institutions. But it's mainly driven by payers, and I think we're just, having said that, we're still just very much scratching the surface of what is possible. Population health obviously is, from a conceptual point of view, to me, translating into benefits for the individual patient. We need to understand how diversified, how diverse patients really are. When I went to med school, we were taught 99%